Hello, very good evening, everyone. This is Dr. MJ Wesley from Pacesdiaries. Today, we are going to see about HIV and some of the common CNS complications. This is our first lecture on the HIV medicine. We are going to talk a lot of topics like common complications and how to approach HIV, what is a pre-exposure prophylaxis, what is a post-exposure prophylaxis in the upcoming videos. All right. Let's go with the very first case. A 45-year-old man with HIV CD4 plus T lymphocyte count of 55 and poor medical follow-up presents with fever, confusion, right-sided hemiplegia, slurred speech. A CT scan with IV contrast reveals multiple ring-enhancing lesions with surrounding vasogenic edema. The ophthalmological examination reveals retinitis. I hope most of the people here will be knowing what is this. Look at here. Look at the finding. Look at the finding in the fundus. Any clues? Look at here. Look at these lesions. 3, 2, 1. Are you ready? Look at the lesion here. Again, CT image of a similar condition. This is CNS toxoplasmosis. The first fundus demonstrated what you call as a headlight in a fog appearance. Can you see here? This is a headlight in a fog appearance. Okay. The second demonstrate choroidoretinal scar in the posterior pole. Okay. Typically, CNS toxoplasmosis appears as a multiple hypodense regions, predominantly in the basal ganglia. Okay, and also at the corticomedullary junction. However, it can be seen also in posterior fossa. It can be varied from 1 centimeter to 3 centimeter, may be associated with Morse effect following administration of contrast, that is nodular or ring enhancement. The typical appearance is a thin, smooth calcification, typically in treated cases. Okay, all right. Next, a HIV patient with hyperattenuating mass near the ventricles. Can we see here? This is a hyperattenuating mass. It's compressing and shifting the ventricles. Can you guess what it is? This is a primary CNS lymphoma. Okay, it shows a solid homogeneous enhancement. Most of this disease is associated with EBV. It may show a mass effect. Here you can see a mass effect here. The ventricles are compressed. All right. And it's positive for thallium SPECT scan. All right. Thallium SPECT scan is negative for toxoplasmosis. That's one of the differentiating features between a CNS lymphoma and toxoplasmosis. Look at this. Look at the image. A 39-year-old Mr. Jones presented to the accident and emergency with confusion, ataxia, decreased visual acuity in the left eye. Can you guess something here? Oh, yeah, white matter is involved predominantly. Can you guess what it is? This is PMLE, progressive multifocal leukoencephalopathy. MRI will show bilateral, asymmetrical, confluent, high-intensity signal with no underlying mass effect. Can you see here? The ventricles are there. There's no midline shift. There's no mass effect. And lesions usually involve subcortical white matter and periventricular areas. There will be progressive neurological deficit occurs as opposed to the multiple sclerosis, which can present with closer MRI findings. All right, but the multiple sclerosis progression is more rapid. There can be aphasia, ataxia, cortical blindness can be seen. It's due to human polyomavirus. Okay. Virus can be demonstrated through PCR, but remember, many normal individuals can also harbor human polyomavirus. That's JC virus, John Cunningham virus. Okay, this John Cunningham virus is the other virus. It also can cause hemorrhagic cystitis in bone marrow transplant patients and interstitial nephritis in renal transplant patients. We'll go to the next case. A 54-year-old HIV positive man with a CD4 count of 50. 1 week history of feeling unwell. There is fever, malaise, headache, and increasingly bizarre behavior. His chest X-ray is unremarkable, but the ball shows eased. A mass lesion detected on CT and MRI of the head confirmed by a positive lumbar puncture for the organism on India ink staining. The CSF opening pressure is 25 centimeter of water. Can you guess what is this? With the CNS, a CSF opening pressure with India ink staining positivity, East, CD4 less than 50. Any guess? Look at here. Look at the lesion carefully. Any clues? Are you getting somewhere? What is this? How does this looks like? This is cryptococcal meningitis. Cryptococcal meningitis is detected by MRI. That can be single or multiple mass lesions in cryptococcal. Okay, typically it will show the Virchow-Robin space dilatation and hydrocephalus can be seen. Okay, all right. So we have to do CT MRI before doing LP to rule out any mass lesion. CSF opening pressure is always elevated with more than 25 centimeter of water. Okay, a direct microscopy will show encapsulated cyst. That is what exactly you are seeing. These are your encapsulated cyst. Antiretroviral therapy plus antifungal therapy, induction therapy with AMB and fluoxetine, then followed by fluconazole. This is the treatment. For any HIV, escalate the heart, then target the infection. Another case, 39-year-old Costa Rican salesman on heart presented with gradually worsening depression, inability to react to his own emotions. There's motor weakness. He has impaired speech, thought behavior, which was progressively worsening. His SPECT scan taken with 99 ethyl citinate dimer is attached as follows. Look at the SPECT scan, look at the history, and tell me what is the most probable thing. Look at the SPECT scan. There are areas where there is no uptake. What do you think it is? Mood changes, okay, weakness, depression. Any idea? This is AIDS dementia complex. Classical finding is progressive clinical depression with alexithymia. What is alexithymia? It's inability to recognize one's own emotions. You don't know you're depressed or anxious, you're stressed, inability. The SPECT will show hypoperfusion, like I said. See, there are places of hypoperfusion. And heart plus behavioral therapy can be tried here. Another case, 34-year-old man with a history of sex with men, presents with 3 weeks of worsening dyspnea associated with fevers, non-productive cough, is tachycardic, is tachypneic, and has a temperature of 38.1 degree centigrade. His pulse oximetry is 86% on room air. He appears thin, moderate respiratory distress, lung examination is unremarkable. What could be this? This is a pulmonary complication. A couple of them. We are going to look into that. Look at the X-ray and look at the CT. Can you see what it is? What's going on over here? What's going on over here? This is the bronchoalveolar lavage of the same patient. Any idea? This is your good old pneumocystitis jirovecii pneumonia. It's the most common opportunistic infection in HIV. All patients with CD4 count below 200 should receive the prophylaxis. The most common and the feared out complication is pneumothorax. Extrapulmonary manifestations are your hepatosplenomegaly, choroidal lesions, and lymphadenopathy. Classically, you will find exercise-induced desaturations in most patients. Sputum often fails to show ball, so you need to stain it with silver stain. This is the prophylaxis for pneumocystitis pneumonia as per Harrison's. First choice is trimethoprim sulfamethoxazole, 1 tablet, okay, double or single strength, QD per. Alternative agents are your dapsone plus pyrimethamine and with leucovorin rescue. Dapsone plus pyrimethamine leucovorin rescue with 2 different dosage. This pentamidine can be given, atovaquone can be given. All right. This is the treatment. Again, trimethoprim sulfamethoxazole, 5 milligram per kg of trimethoprim, 25 milligram per kg sulfamethoxazole. We give around 6 hours per oral. Alternative agents are your ataucone, clindamycin with primaquine, pentamidine. Adjunctive agent can be prednisolone or methylprednisolone. Here is another case. 41-year-old man with HIV infection complains of persistent, rather watery diarrhea that has been continuing for several months. He has noted no blood in his stool but has lost weight. He has not been taking antiretroviral therapy. His CD4 lymphocyte count is 48, less than 50. Guess what it is? The stool is showing oocyst in acid-fast staining. 3, 2, 1. Guess what it is? Yes, it's cryptosporidiosis. You have to start hard, supportive treatment, and one drug that can be tried is nitazoxanide, 500 milligram BD, 3 days. Other infections that can cause diarrhea in HIV are your MAC, giardiasis, and CMV. Don't forget. So here is a big case. A 39-year-old transgender female with no significant past medical history is presented to the hospital with complaints of persistent cough of 4-month duration. The patient stated that cough was productive with whitish sputum and was associated with weight loss, night sweat, loss of appetite, low-grade fever. 3 weeks prior to the hospital admission, she had visited the emergency room with similar complaints and discharged with oral antibiotics for community-acquired pneumonia. However, the symptoms have persisted despite completion of antibiotic therapy the second visit to the hospital. Chest examination is revealing a good bilateral air entry. There is diffuse crackles worse on the right upper posterior lung. A resonant percussion lab showed these values. The viral load is high. CD4 is at the lower end. PJP pneumonia is negative. Look at the X-ray. Any guess what is this? Look at the CT. Look at this area. This is MAC. Okay. What MAC shows typically gives a nodular bronchiectatic disease. Okay, typically we give azithromycin and clarithromycin with ethambutol and rifampicin. Azithromycin or clarithromycin with ethambutol or rifampicin plus rifampicin. In case of localized disease, upper lobe disease, lobectomy or pneumonectomy can be considered if the patient fails to turn sputum negative after 6 months. You give a treatment for 6 months. At the end of the 6 months, still they are not turning sputum negative. You're going to go for lobectomy or pneumonectomy. In cavitatory disease, same treatment as above, plus streptomycin can be used as a first line alongside other drugs. Amikacin liposomal inhalation can be considered here. In cavitatory disease, resistant disease should be considered for surgery, which I have explained above. In case of MAC-induced hypersensitivity pneumonitis that can occur, we have to go for prednisolone. All right. Look at here. This is one of the complications of HIV. 35-year-old homosexual man with HIV infection presents with recurrent, recent, painless, purple skin plaques on his lower legs with generalized lymphadenopathy. He has similar lesions on his trunk and a purple colored mass on the hot palate. You all would have got it. What is this? This is your Kaposi sarcoma. This is a staging. If you're interested, you can read. It's due to HHV8. Remember one thing, it is also seen in non-immunocompromised middle-aged elderly people as well. The first stage is a macronodular stage, lesion typically localized to the lower extremity. The second stage is an infiltrative stage where in the lower extremity itself, it will start growing around the wide areas. The third stage, we call it as a florid stage. Ulcerated lesion will involve one or more limbs. Fourth is a disseminated extends to additional areas. Okay, the treatment is you have to start hard, surgical excision and cryotherapy. Systemic drugs approved are lenalidomide, bortezomib, gemcitabine and paclitaxel in highly refractive cases. All right, here is the classical complication of HIV. Look at the tongue. I don't need to read the case history for you. Look at the tongue. You can tell. There are two things, candidiasis and leukoplakia. But remember one thing, leukoplakia cannot be scrapped out. Candidiasis can be scrapped out. Next thing is leukoplakia has a malignant potential, whereas candidiasis does not have any malignant potential. Thank you so much for listening to this short videos from Bite Size Medicine, Paces Diaries, and we will come up with more such exciting videos. If you want any topics to be discussed, if you find any topic to be, kind of confusing, please leave a message. We are more than happy to help you out with that. Thank you so much. Have a great day. Bye-bye.